In January of 2026, Florida made a single budget decision. One line item changed on a spreadsheet inside the Department of Health. That single change cut 16,000 people off their HIV medication, not because the drugs disappeared, not because the patients no longer needed them, because the state quietly redefined what it means to be poor enough to qualify for help. The threshold dropped from 400% of the federal poverty level to 130. In real numbers, that means a person earning more than $20,748 a year lost access. They called it a $120 million budget fix. Johns Hopkins epidemiologists called it 4,312 new HIV infections waiting to happen. This is not a story about illness. This is a story about a financial decision and the hidden price tag on the other side of it. By the end of this briefing, you will understand the mechanism. This is Luxona. The program at the center of this story is called ADAP. The AIDS Drug Assistance Program has been a lifeline since Congress created it through the Ryan White Care Act in 1990. Every state in the country runs one. Florida runs the largest. As of 2025, Florida's ADAP served more than 32,000 clients. These are not people waiting to get HIV. These are people already living with it. People who, when they take their medication every single day, can suppress the virus to undetectable levels. Undetectable means they cannot transmit it. Undetectable means they live essentially normal lifespans. Undetectable is not a luxury. It is the mechanism that stops the spread. When treatment stops, the virus becomes detectable again. When the virus becomes detectable, transmission risk increases. When transmission risk increases, new infections follow. This is not a theory. It is the documented chain reaction. And Florida just cut the program that was holding it together. Now meet Michael Rajner. He is an HIV-positive resident of Fort Lauderdale. He has been managing his condition with medication accessed through ADAP. When he heard about the Department of Health's changes in January, he did not wait. He began advocating immediately. He testified. He organized. He showed up to every legislative hearing he could reach. He is not a lobbyist. He is not a policy analyst. He is a person whose access to medication was placed on a spreadsheet and nearly deleted. For Michael and 12,000 people like him, the $30.9 million emergency bill was not a policy win. It was survival extended by 90 days. Now meet the man at the center of the financial decision. Florida Surgeon General Joseph Ladapo testified before the Senate Appropriations Committee in January of 2026. He estimated approximately 10,000 people would be affected by the eligibility change. He cited a projected $120 million budget shortfall inside the Department of Health. What he did not provide was a detailed public budget breakdown. The state had not released a public ADAP budget in over a year. The same program that serves 32,000 clients, processes millions in federal rebates annually, and has been operational for over 3 decades, had no public financial accounting. David Poole, who oversaw Florida's AIDS program from 1993 to 2005, testified that state records showed $120 million in manufacturer rebate revenues from the prior year, the same amount as the claimed shortfall. Those rebate revenues were not publicly disclosed in Ladapo's presentation. The math was not adding up, and 16,000 people were about to lose their medication because of it. Here is where the financial architecture becomes undeniable. One Gilead HIV medication, called Biktarvy, carries an annual sticker price of nearly $61,000 per patient. Biktarvy was the most widely prescribed HIV medication in the country. About 60% of Florida ADAP enrollees relied on it. On March 1st, Florida removed Biktarvy from the program's formulary entirely. Gilead Sciences is a pharmaceutical company that reported billions in annual revenue from that single drug. The AIDS Healthcare Foundation ran full-page ads in 5 major Florida newspapers calling out Gilead's pricing directly. The ads called the company greedy ad. They argued that years of Gilead's price increases created the financial pressure that pushed Florida toward the cuts in the first place. The state was absorbing $61,000 per patient per year for one drug. Federal funding for ADAP had remained essentially flat for over a decade. The cost curve went up. The federal support stayed flat. The state was left holding a gap that grew bigger every year. And when the gap became too large to ignore, 16,000 patients became the solution. Now apply the financial lens the spreadsheet missed. Each HIV patient who loses access to medication and stops achieving viral suppression becomes a different kind of financial equation. When a person living with HIV develops advanced opportunistic infections, they do not disappear from the healthcare system. They show up in the emergency room, they require hospitalization, they require intensive treatment for conditions that are far more expensive than the daily medication that would have prevented them. The cost of a single HIV-related hospitalization can exceed $50,000. The cost of Biktarvy for an entire year is $61,000. Those numbers are close. But here is what changes the math entirely. The daily medication costs $61,000 and keeps the patient stable, working, and out of the hospital for that entire year. The hospitalization costs $50,000 or more for a single acute event. And after that hospitalization, the patient still needs medication. They still need ongoing care. They still potentially transmit the virus to others during the period they went undetectable. This is the cost shift the spreadsheet does not calculate. The state saves money today on ADAP. That cost transfers to Medicaid, emergency rooms, and hospital systems. A different budget line, a different fiscal year, but the same taxpayer paying the bill. Johns Hopkins epidemiologist Melissa Schnur ran the numbers. Her preliminary analysis found that the ADAP cuts could lead to 4,312 more HIV infections in Florida from 2026 to 2030. That is a 28% increase in new infections compared to if ADAP had continued unchanged. Each new HIV infection carries a lifetime treatment cost. The Centers for Disease Control has estimated the lifetime cost of treating a single HIV infection in the United States at approximately $500,000. Multiply 4,300 new infections by $500,000 each. That is $2.15 billion in future healthcare costs. The state saved $120 million. It may have created $2 billion in future liability. That is the math the press release did not include. There is more where this came from inside the vault. The members inside the vault are already 2 episodes ahead of this. The link is below. Now look at what happened next, because the story does not end with the cuts. The AIDS Healthcare Foundation filed a legal injunction to block the restrictions. An administrative judge approved an expedited hearing. Over 100 advocates attended a candlelight vigil in Fort Lauderdale. The outcry reached Congress. The Real Housewives of Miami went to Capitol Hill to advocate for ADAP funding. And in a rare unanimous vote, the Florida legislature passed emergency bridge legislation. Governor Ron DeSantis signed it on March 24, 2026. The bill allocated $30.9 million in stopgap funding through June 30th. It restored eligibility to 400% of the federal poverty level. It required the Department of Health to submit monthly financial reports to legislative leadership beginning April 1st. 12,000 people got their medication back. But Biktarvy remains off the formulary. Patients who relied on that once-daily pill now face more complex multi-drug regimens, and the stopgap funding expires on June 30th. The long-term structure of ADP is still unresolved. Florida lawmakers ended the regular legislative session without a final budget deal. 16,000 people came within weeks of losing access to their medication. They got a temporary fix. They do not yet have a permanent one. Now look at Florida inside the national picture. As of 2025, Florida ranks third in the nation for new HIV diagnoses. Approximately 4,290 new cases annually. That is 11% of all HIV diagnoses in the United States. Miami-Dade County alone reports a diagnosis rate of 33.3 per 100,000 residents. This is not a state at the tail end of the epidemic. This is a state at the center of it. Cutting the program in this environment is not a cautious fiscal decision. A Johns Hopkins simulation study showed that if the federal Ryan White HIV program disappeared entirely, HIV infections in the United States would increase by 73%. Florida did not eliminate its program, but it came close enough to trigger the same chain reaction. And 23 other states are currently implementing or considering similar reductions. Florida was not an isolated decision. It was a test case, and the country is watching to see if it holds. Now look at who built the architecture that made this crisis possible. Federal ADAP funding has remained largely unchanged for more than a decade. Congress has not passed a meaningful increase to the Ryan White program in years. Meanwhile, Gilead Sciences raised the price of Biktarvy repeatedly since it entered the market. The drug costs $61,000 annually per patient as of 2025. That is not the cost of manufacturing the medication. That is the price set by a company holding a patent with no meaningful competition. The state is required to absorb that price to keep patients on medication. The federal government does not cover the full cost. The gap between what the federal program funds and what the drugs actually cost has widened every single year. Florida is not the first state to crack under that pressure. It is just the largest program and therefore the most visible collapse. The pharmaceutical pricing is the accelerant. The flat federal funding is the structure that made the fire possible. The patients are the ones standing in the building when it catches, and nobody in the pricing decision, the funding decision, or the eligibility decision will be the one paying the bill. The taxpayer pays it, the patient pays it first. This is the mechanism behind the headline. A state with a $120 million budget problem. A pharmaceutical company charging $61,000 per patient per year for a single drug. A federal funding structure that has not kept pace with rising costs for over a decade. A surgeon general who testified without releasing a public budget. And 16,000 people caught in the middle of a financial architecture nobody built to serve them. The state called it cost containment. The epidemiologists called it a public health disaster in slow motion. The $2 billion future liability does not appear on any current budget line. It will appear later, in emergency rooms, in Medicaid claims, in new infection rates that compound every year. The funding gap stays open. The ledger is clear. The decision was made, and the true cost has not been paid yet. If you are the kind of person who wants to see the architecture and not just the headlines, you belong here. Most people see the news. We show you who built it. Subscribe and stay ahead of it. Welcome to Luxona, where systems are exposed.